And YouTube Live, and I hope that you're all enjoying this summer that is going all too fast. And here in Minnesota, we've had a record-breaking summer with heat over 90 degrees for like 21 days this summer. I know for some of you in the South, that's like a typical month, but for Minnesota, that's a record. And so we have definitely been wearing the shorts, keeping cool, and I've been keeping the air conditioning on here in my home office here in Andover, Minnesota. But it's a pleasure to have you with me tonight. And I just want to thank you for taking time out of your schedule tonight to just basically strengthen your practice as an educator. And I just want to thank you again for coming out tonight, and just throw your name in the chat. I'd love to know who's out there tonight. I've got the chat here to my left, and just keep an eye on the chat box. And I just want you to know that this is a dialogue. I've got some things I'm going to share today, and tonight we're going to be talking about transforming the classroom using case-based learning and some practical ways to really do more than flipping, but to really bring that meaningful active learning into your classroom, to really engage your students, to get them participants in the learning process. But if you're new to this Facebook Live, my name is Keith. I'm the founder of Keith RN, and I 9 years ago began a journey to transform my classroom when I read this book, Transforming Educating Nurses, A Call for Radical Transformation by Dr. Pat Benner and her co-authors with the Carnegie Foundation's research. And really, my challenge and my passion is to empower educators to implement the educational best practices that Dr. Benner advocated, and making that real. And so we'll talk about that in just a little bit. But when we look at some of the challenges facing nursing education, we continue to have a disconnect between how nursing is taught and how it's experienced in the real world. And we've had this thing called the academic practice gap that's been going on for over 50 years, almost 50 years in the nursing literature alone. We need to take this gap and we need to close it. And it's my passion. I'm a man on a mission with Keith RN to bring practice-based realities, taking my lens of recent clinical practice. I've been a nurse for 36 years, all of it at the bedside. Also a nurse educator as well. And I never left the bedside, having a Baylor weekend position. I work every weekend, taught during the week. And so maintain that connection to practice. And that's my passion, is to bring practice back into how we teach, with the ultimate goal, not necessarily to pass the NCLEX. That is a program objective, but let's make improving patient outcomes, improving patient care, our primary purpose in nursing education. And that's my passion. And I know that's yours, or you wouldn't be joining me tonight. So thank you so much. And I just wanted to basically kind of just throw it out there. What questions do you have as an educator catching this live stream tonight? Because you're watching live, you get to ask questions and I'll answer them. I've got the chat. But when you look at clinical judgment, what questions do you have? And what do you need to know to have clarity so you can confidently teach it, preparing your students for practice as well as for next-gen licensure? And we've been doing a series this summer on clinical judgment. And so if you've missed it, we've done this will be our fourth out of a seven-part series. If you missed the first three parts, we've had some wonderful dialogue. On part one, we talked about defining clinical judgment. And if you go to my Facebook page, Keith RN, Think Like a Nurse, under the header, under the banner, there's a video section. And all you need to do is go to that link. And basically, you'll see all the previous Facebook Lives and the most recent ones in this series. And you can share that link with your faculty team. So if you're finding this series helpful, and tonight our content on transforming classroom teaching, I really want you to share that link. My goal is just to get the word out. Let's get some leaven out there and let's season nursing education with practical educational best practice strategies. And so again, our first part was on defining clinical judgment. And the real big takeaway from part one is to remember that clinical judgment is an outcome. You can't teach it directly. So therefore, there's no product, there's no magic kind of textbook or resource to help us develop clinical judgment. But we need to bring critical thinking and clinical reasoning together equal the outcome of a correct judgment. And critical thinking is that knowledge that your students must be able to possess to know and understand your content, not just memorize it, and then be able to reason or clinically reason is that thinking in action at the bedside. Well, guess what takes place in our classrooms? We're developing critical thinking. And so when I want you to look at the classroom as your learning lab of critical thinking, getting your students to understand essential content, remember this, that if they're unable to critically think by understanding what's most important to whatever content you're teaching, they will not be able to reason with that knowledge and they won't make the correct judgment. So what takes place in your classroom is ground zero to develop clinical judgment. So I want you to see the classroom differently as an educator. It's not just going through your slides. It's not just going through your content. Your students must understand the knowledge and the content you're teaching. And I would also encourage this caveat, your students need to come to class prepared. We need to raise the bar of classroom instruction. If we expect our students to come to clinical prepared, which I know that all of you do, if you teach clinical, you just can't show up to clinical. You got to be prepared with the right uniform, your stethoscope, and all the preparation to prepare to provide safe care. Our classrooms are just as important. Let's raise the bar. Have our students come to class prepared as well. Just kind of my thought. In part two, we talked about frameworks to teach clinical judgment. And again, there's always going to be a place for nursing process. Just because it's been around for 50 years doesn't mean nursing process is going out of style. Nursing process remains foundational to develop clinical judgment, but then we need to integrate it with Tanner's framework of clinical judgment, because Tanner's is a practice-based theoretical framework. And the NCSBN model that some educators advocate as our curriculum framework, it's a test model. It's an evaluation model. If you want to prepare them for next gen, sure. But it's not a model that was ever meant to inform practice. And we're just going to exacerbate the academic practice gap by making the NCSBN model our focus. Now, Tanner's framework aligns with the NCSBN, and they are similar. But let's put first things first, and that's Tanner's. Part three, why case studies. That was the one we did 2 weeks ago. Talked about why case studies are one of the most foundational and practical strategies to develop clinical judgment with your students. And so tonight we're going to be talking about transforming the classroom. And so those questions that you have, I'm going to look in the chat right here, but I want you to be thinking about, how do your students respond to active learning in your program? Do your students resist and insist that they're sometimes just teaching themselves? Or do you struggle to put your content on a diet? Infobesity, TMI are all too endemic in many of our classrooms. And really, when we expect our students to know too much, they retain little, if not most of it, and they forget most of it. So we need to basically go down that path and do all that we can And so anyways, Carol Daly says this series is binge worthy. I wouldn't go there, Carol. Don't do a Netflix binge watch on Keith RN, but I hope you're finding it helpful. And so I just want to kind of scroll back and say, wow, it is such an honor to have people like Ashley from Nebraska, Nadine from Baltimore, Destiny, a new instructor here. Destiny, welcome. I love new faculty because you bring in a practice-based perspective. You are valued, Destiny, and they need you in your program. Jennifer in New Hampshire, and got Lynn from Fort Morgan, Colorado, and Kate from Nebraska, Carol from Chicago. Wow, what a pleasure. Thanks so much for just joining me tonight. And so as I look at Ashley's has a question, let's start with some questions. Ashley says this: since your last session, I have made so many more case studies based on Tanner's framework. Thanks for increasing my awareness of the importance of these and using them effectively. And Ashley, that warms my heart. That makes I could be at home with my family right now, and I'll get there once I finish this Facebook Live in about another half hour. But, the four processes of Tanner. This is why nursing process and Tanner's framework align so beautifully. Tanner's framework, the first step of noticing. What are you noticing as you read the chart, as you assess your patient? That is the first step of clinical reasoning. We're going to use a case study tonight. I'm going to demonstrate one of my Keith RN cases that'll kind of bring Tanner nursing process to life in a new and unique way. But those steps of noticing, interpreting the data, then generating the meaning of the data leads to the priority, or that's going to lead to the response, which is the third step of responding, the fourth step of evaluation, reflecting. So Ashley, Tanner never goes out of style. Keep going there and keep using that. So excellent. And we'll be talking about Tanner in just a little bit. Lynn says this: my biggest challenge is adapting the use of case studies to the level of unlicensed assistive personnel. The CNAs and MAs need to also do more thinking. They need to think about what they are measuring or hearing, but most resources are written above their level. Anyone have any ideas? And I would throw this out to the chat. We are all educators. We've got dozens of educators around the country here. So let's put our heads together here and let's answer Lynn's question, because I'll be honest with you, Lynn, I have focused on the LPN, LVN, registered nurse undergraduate program with all of the cases I've written, my tools. But yet what I've also noticed as well, Lynn, is that what my case studies do is they provide a clinical context that you can pull out from the scenario even, and then adding the NA responsibilities of what happens, as it relates to some of the tasks related to a patient with this scenario at a very basic way. But you can pick and choose and kind of pull what really is needed and most relevant to the level of students that you're teaching. And that principle applies to, for example, the Keith RN cases that I've written, where yes, some of the content may be above the scope of practice of an LPN, or it may not be relevant to fundamental students. There's things on, lab values and pharmacology they may not have had yet, but you can use the scenario, because one of the things we must do, according to Benner's work from the Carnegie Foundation, one of the paradigm shifts, contextualize your content to the bedside of patient care. So Lynn, what I would encourage you to do? Lynn, just as I have taken case studies and have basically taken the most common scenarios that I see as a clinician in practice at a large metropolitan hospital, and basically take the scenarios that your nursing assistants need to think at a basic level. Now, they're not nurses, obviously, but Lynn, what are the most common scenarios that nursing assistants experience that will require thinking at a very basic problem solving level? And I want you to create those cases. A good case study just takes about one concise paragraph to get started. And then you bring in some of the Tanner's framework. What do you notice? in this scenario? Or what are you noticing with your patient? Because noticing also applies, it's really a life skill. It's a people skill. When you basically go to the state fair, what do? You notice lots of people and you notice some of the quirkiness of some of these people. It's the same thing that we do in practice. We're noticing certain things, but we have to notice what's important. So what's important to a nursing assistant, Lynn, is how I'd love to see you create some scenarios. And if you want to share them with me and collaborate, my email, I'll just pop it on the screen for anyone who has questions. Or if I didn't get to your question, feel free to contact me. And would look forward to that opportunity. Jennifer, I'm just going to kind of go to some of the questions and challenges here and start right there before I go into what I'm going to share. We struggle with participation. And so, Jennifer, your students struggling to just kind of get them engaged. And, that is a common challenge that all of us, I think, have as nurse educators. And I think that we just need to raise the bar of what are we expecting for participation. So for example, do we have some tickets to class? Do we have pre-learning activities that require students to basically do a simple activity? And I'll talk about that if I have time at the end of this Facebook Live. But again, we have to they have to ultimately drink. But we as educators must lead our students and guide them to having expectations of participation, as well as then using the small groups and other things that we can do to encourage it. But you're right, we can't force a student to drink, and it's got to come from within them. So I hope that your students have that same desire, Jennifer, to want to be there, want to learn, want to be the best. I don't think any nursing student wants to be a crappy nurse and they harm their patients. That's not why they're there. But sometimes they're stressed, they're overwhelmed. And you know what, Jennifer, if we're honest, sometimes we as educators are part of the problem. We put too much, we're like the Pharisees of the Old Testament, putting burdens that people could never bear with the demands of the law. As educators, we can burden them with too much reading, too much information, and they study needless hours on content that's not relevant to first-year generalists. So let's take a step back and kind of be holistic with why our students may be stressed or not engaging. Just a thought. And if you disagree or have a comment to add to that, to anything I'm sharing, you know what? There's no holy grail. I want to encourage any participation and look forward to your feedback. Tanya says this: I've been using more case studies more and more. My overall test scores have increased. They are grasping the content and staying engaged. And you know what, Tanya, that's so encouraging. I'm going to put that on this chat screen. And that's exactly, Tanya, what you're doing is not rocket science. Dr. Pat Benner and the Carnegie Foundation presented those same principles 11 years ago in educating nurses. And I think I'm going to just highlight what those things are, because what you're doing, Tanya, is that case studies do 3 paradigm shifts that Dr. Benner advocated. And I want you to know, people kind of maybe see me as the case study man, and all I think about are, just unfolding case studies. Well, there are other strategies of active learning. But let me just say this. It's kind of like, how many of you like to go out to eat? But 75 to 80% of the time, I go to Raising Cane's because I love their chicken fingers. Sometimes I'll go to Arby's, but not as many. When it comes to active learning, it's the same way. There's a foundational strategy that we as educators need to use. And I think unfolding case studies certainly fit that bill, but you got to mix it up. So again, got to go to Arby's sometimes, can't always do Cane's. So therefore, do the same thing. But what I want to get back to with the paradigm shifts, I want to just encourage us as educators to recognize that we need to follow the truth of educational best practice, not simply doing what's comfortable or convenient, because the paradigm shifts that Dr. Benner advocated in educating nurses are 3 simple shifts. And you're doing them, Tanya, so thank you. First shift: contextualize your content to the bedside of patient care. Case studies are a great example. They do just that. Second, integrate class and clinical learning so that they basically are no longer in separate spheres, but they're bringing them together. When you do a good case study or any other active learning strategy that brings practice realities, clinical imagination, you are integrating class and clinical learning. They don't need textbook information in your lecture. They can read that. They need to see it come together in the classroom where you're practicing clinical realities, and case studies provide the low fidelity simulation of thinking. And third, we need to emphasize clinical reasoning. Tanner's clinical judgment model really is a reasoning framework of noticing as a reasoning process, interpreting the data is a clinical reasoning process, responding with the plan of care is nursing process and clinical reasoning, evaluation is nursing process and clinical reasoning. And case studies with the right questions and the right framework can do just that, Tanya. So really, it doesn't surprise me. It shouldn't surprise you either. Implementing educational best practices will get you the results that we need to see to develop the clinical judgment. Our students are lacking, but we can be a part of that needed change. So thank you for just sharing that. And I just basically, I see Tanya adds another question or another thought here. I taught a CBC breakdown. I had the class build the case study from the CBC results. They loved being empowered to do this. That's, I think CBC, are you talking about, I'm not quite sure if you're talking about concept, that's not concept-based curriculum. That's not, are you talking about a complete blood count? I think you're talking about a complete blood count because you're talking about results. And that's a great kind of, again, let's learn from what Tanya is doing in this Facebook Live tonight. And, when you have lab results that are abnormal, you have a simple scenario. Your patients in the clinical setting, those are case studies you can use for the next semester. One clinical and the 8 students who had 8 patients, those scenarios, minus HIPAA and modifying them, those are your case studies you can use to bring clinical realities, clinical thinking. Change the name, the gender, the age, the ethnicity, obviously. But you can simulate and bring those clinical realities. So great job, Tanya, and keep it up. And if you have some other thoughts or anything else you've been doing in your program, please pop it in the chat. Ashley says this, I made tickets to class and assigned patients to it. Most are case studies. They only get the points when they turn it in and are present in class. Great work. And, again, this is how we can change culture. Nursing education is in need of radical transformation. That's the subtitle, by the way, of Dr. Benner's book. I didn't say it, she did. That doesn't mean just flipping classrooms or tweaking your content. It means a radical paradigm shift of doing things completely differently. And so well done. And let's raise that bar of classroom participation. Let's make those tickets to class. I would just have one little thought, Ashley. Why not make the points make the tickets an expected part of your course? And if they don't turn it in, they lose a point or 2. I've learned that students will do just about anything for a point or 2. Jennifer has this question. I struggle with my class with 100 students with Patho Farm. Wow, Jennifer, you're teaching some heavy content to a lot of students. In Med Surg, I have 33 or so, which is better. And so, when we look at large classrooms, I had 80 students when I was an instructor teaching fundamentals, and I developed my first gen Keith RN case studies back in 2011 when I was just an unknown educator with a passion to change things up. I had 80 students in my classroom, Jennifer. I want you to know that I kind of was the old Johnny Carson, Jay Leno, playing the classroom in that way, like they played the audience back in the day. A little old school, but that's what I remember from my growing up. And as educators, you kind of can do the same thing with a large class. Sometimes small group, that's four groups of 20 isn't going to work for 80 or 100 students, but expect your students to come to class prepared, engaged with the content, having read the textbook because you had a pre-class assignment of some kind, a portion of a case study, for example, and then you basically then have them, you present the case on the PowerPoint, the slide, and you begin to walk through it, and you just work the audience, work the classroom. Just a strategy that I used, that I was able to do with 80 students successfully in that context. And so Lynn has this comment, and I'm going to, I hope to get to my to the presentation, but it's great to have these questions. I think they were a reflection of what a lot of us are struggling with. I'm going to do some more work on Tanners and also dig in more to all the case studies I have in my bookshelf. I have subscribed to your webpage and love it. I was having brain block. Well, good. I hope that I can get that moving forward, so you basically can remove the brain block and keep things moving forward. Just got some great feedback here, and so love to see the feedback. And can you explain concept-based learning? Well, that's a little off topic for tonight's presentation, but in essence, conceptual-based learning is identifying core concepts. For example, I'm an ER ICU nurse, so I focus on the ABCs of airway, breathing, circulation. Those concepts are oxygenation and perfusion. If you have a problem like sepsis, those concepts are inflammation and immunity and infection. And concepts are a really powerful strategy to basically kind of decrease content load. So we're getting our students to understand the concepts and then be able to use exemplars and the most common examples of those concepts in our curriculum. So that's the best I'm going to do right now. And I'm going to jump in. And I got through most of the questions, and I'm thankful that we had that opportunity. But let's dig in and let's talk about case-based learning with our classrooms. And what I want us to remember is that case studies are not just case studies. They are low fidelity simulation. That's true. They replicate the thinking, the higher level thinking, if they're the right case studies. And this is what I learned as a new educator. Even the big publishers' workbooks and the case studies that I was able to obtain on the textbook or in purchase, they weren't as strong as I expected. They emphasized knowledge application and didn't go into the deeper thinking skills as consistently as I would have liked. But when you have clinical reasoning case studies that emphasize the clinical reasoning skills of Tanner's framework, now it becomes a low fidelity simulation. It replicates clinical realities. And as I shared last week, simulation case studies to have a noticeable impact on critical thinking in nursing students, to really develop those critical thinking skills, 6 to 8 case studies a semester. Let's keep it simple, every other week. And ideally, every week, we're bringing active learning. Doesn't always have to be a case study, but something that's bringing practice realities into our classroom. And so let's make that a priority and what that looks like. And so one of the cases that I've developed in my practice is when I began Keith RN and just created cases for my students, and then went from there to create the website, and didn't go to build a business or to build what I do with my website. It just kind of organically grew. But skinny reasoning is is probably the most versatile level that I've developed. And skinny reasoning, I got that from Skinny Cow, Skinny Chocolate. All the goodness of Tanner's framework in a very short and concise case study of about 4 pages. Has 2 parts. Part 1 is only 2 pages. That can be a ticket to class. I'm going to demonstrate that in just a minute so you can see for yourself. And then part 2 basically asks 5 simple questions that are reasoning questions to interpret and flesh out the meaning of what was noticed and interpreted in the clinical scenario. So let's take a look at what this case study is. And what I'm going to do right now, I'm going to share my screen. So I'm going to just kind of we're going to go, and I think we're going to make this work. I'm going to flip on my window here, and you should hopefully, there you go. It's a little distorted, which I don't like. Let me see if I can change that or do it a little. Let me play with my windows here because it looks a little distorted on my screen, which I don't like. And I apologize for that, but we're going to figure this out. I'm an ER nurse. I'm used to running on the fly. And let's just see which one of these screens is going to work best. You know what? We'll just go with this one, and we'll keep me on the side. This is a simple scenario. It's an ER scenario. And I love ER scenarios because they're ambiguous. And it helps students really you don't have this problem defined. But here is our problem. And we're going to use Tanner's framework, which is what I use in my case studies of what are you noticing? And then what is the interpretation or the significance of the data? So let's go with our scenario. Jean Kelly is an 82-year-old woman who has been feeling more fatigued the last 3 days and has had a fever the last 24 hours. She reports a painful burning sensation when she urinates, as well as frequency of urination the last week. Her daughter became concerned and brought her to the ER when she did not know what day it was. She is mentally alert with no history of confusion. While taking her bath today, she was weak and unable to get out of the tub and used her life alert button to call for medical assistance. So, using Tanner's framework of what are you noticing? The NCSBN just simply says the same thing. Recognize cues. Let's apply that to this scenario. Case-based unfolding scenario. What are you noticing here that is concerning that you'd want your students to be pay attention to? Well, she's 82 years old. She's old. She's elder. She's an older adult. She's at a higher risk of developing a potential problem. She's had a fever. And again, what does a fever mean? What is the significance of a fever? That inflammatory response. There's an infection present. Okay, let's keep going. Painful burning sensation when she urinates, as well as frequency. If your students have had that content of UTI, that should be blinking to them loud and clear. But then she became confused. What's up with that? Why would she have confusion? Is she having a stroke? Well, no. In fact, if your students have read the textbook, they know that the elderly can have confusion as a result of the metabolic derangements with an acute infection. So we want our students, again, and with Keith RN cases, there's no multiple choice. It simply states, what clinical data do you notice? And then write it out. Then the next step, why is it clinically significant? Just like a nurse needs to know the rationale for the plan of care, you need to know the why of clinical data. And that's where your pathophysiology and that knowledge really comes into play. That's why that is so important. So now let's go to our vital signs. Her vital signs are 101.8. Her pulse is 110. Her rate is 24. I'll kind of maybe mod this up a little bit so you can see it a little better. I think that's good. Her blood pressure is 102/50, 98% sat on room air. She's also got right flank pain, 5/10. That's continuous. So again, every vital sign is vital. So now we ask ourselves the same question. The 1-2 punch of Tanner. What are you noticing? What's the clinical significance, or what does it mean? So we got the temperature, 101.8. Boy, that's a little too high. She's got that febrile response from an infection or inflammatory response. That's the why. Her pulse is tachycardic. She's 110. That's a little higher than I'd expect with a temperature of 101.8. If your students understand perfusion and that concept of perfusion, could be a compensatory response due to volume deficit or dehydration. Or what is every patient with infection at risk for? Septic shock. We don't know that yet, though, so let's get more data. Rate is 24, it's too high. Her blood pressure is soft at 102/50. 98%. She's okay with her SATs for right now. But what about this right flank pain? Thought she had a UTI. That painful burning frequency. What is the meaning of right flank pain? Well, if you know your urinary system, you know the bladder is here, the ureters are here, and your kidneys are here. That flank pain is likely. Don't have a diagnosis. We're not medical doctors, but we as nurses need to have knowledge of pathophysiology to interpret this data. This pain could be the progression of a UTI to pyelonephritis. It's just a possibility. With her nursing assessment, she's comfortable. Her breath sounds are clear. She's alert and oriented ×2. Abdomen is soft, non-tender. Frequency of urination persists. Skin integrity is intact, but her lips are dry and her oral mucosa is tachydry. You know, I want to teach, I hope that all of us are teaching our students that volume deficit isn't just tenting of the skin. That's really not, I don't use that. I haven't found it to be that helpful in practice. But as an ER nurse, I have every patient I'm concerned about with fluid volume, open the mouth. Is it shiny and full of saliva? We're hydrated. Tachy-dry, lips dry, we got a problem. They're on the dry side. So let's teach those practical, practice-based strategies using a case study, using your cases, using the scenarios that you have experienced in practice. Now let's look at our labs. Let's look at our diagnostic results. We can see her sodium 140, K is 3.8, glucose is 184, creat of 1.5. You can see the most recent. We want to do two things with all of our diagnostic results as well as with our vital signs and assessment data. We trend everything. We compare the most recent to the current of all of our vital signs, our assessment data, and our diagnostics, and we see what direction. Going up, down, improving, not. That's what NextGen NCLEX is going to be assessing. All of those, the 2-column, 3-column matrix and all those crazy multiple choice forms, they're assessing those same dynamics of noticing what's concerning, the trend, what does it mean? Using Tanner's framework, you'll all prepare your students for both practice, licensure, and next gen, no worries. But let's look at our CBC. We got a white count that's up at 13.2. Neutrophils are 93%. And again, look at those trends going from 8.8 to 13.2 on the white count. Again, trending is an essential clinical reasoning skill. And it's really important for us as educators to recognize that the gift of Tanner's framework is that it deconstructs this big construct of clinical reasoning and breaks it down. And Lassiter's clinical judgment rubric for simulation breaks the 4 processes of Tanner into 11 constructs, including concepts like trending and looking at the data, looking for patterns and the connection of relationships. But look at her lactate, it's 3.2. Your students know what lactate as a serum marker of perfusion. You know, it's lactic acidosis, anaerobic metabolism, Krebs cycle, pathophysiology needs to be known by your students to develop the critical thinking that lactate represents and understanding the significance of lactate, or it won't be recognized. They won't understand it. Oh, lactate, what is that? I don't know. And they don't go further. Her UA is clearly positive. I'm not going to take the time to go into that. But again, what we've done in the first 2 pages of these first 4 slides are noticing, then interpreting correctly. Your students can do these first 2 pages on their own, having read the textbook. Then they apply their knowledge in small groups, bring the case study as a ticket to class. And now you are going to be the guide on the side in your classroom. And you're going to go through these next 5 questions in small groups with your students. You're not going to be on the stage anymore. You're going to maybe do a 15-minute lecture, concise, practice-based, need-to-know first-year generalist. Cut your slides in half. If you have more than 20 slides, 25 at the most, it's infobese. You got to put on a diet. Now we have 5 very important reasoning questions that align with the preparation of the case study. In these cases, I kind of structured them how I experience clinical practice as a nurse. I read the chart, get that scenario. Then I take my vital signs, first set of vitals, assessment, look at my labs, put it together. First question. After interpreting relevant clinical data, what is the primary problem? So, Next Gen asks to generate hypotheses. So you could generate more than one, but then determine what's the most likely problem. Same thinking. So we're using the same Next Gen thinking of recognizing cues, analyzing cues. Now we're generating hypotheses of Next Gen. So again, I want you to see that Next Gen and Tanner's and clinical reasoning all go together. These cases I wrote 9 years ago, way before Next Gen was even on the scene. But Tanner's framework was, and I recognized the value and integrated Tanner's framework from day one as I wrote my cases as a new nurse educator. And then interpreting the data, what's the problem? And then have your students then identify and put in their own words the pathophysiology. No regurgitation. You look at, what is the problem here? See, this is where we need to step back. Does this patient just have a UTI or a pyelonephritis or that lactate of 3.2, the pressure that's soft, the heart rate that's 110? Could she be septic? If your lactate is over 2.2, red flag. It's sepsis until proven otherwise, and it's a problem. So I'm going to say that my patient's problem is a urosepsis. And I'm not being a doctor as a nurse. I'm just interpreting the data and then making a hypothesis to plan my care. I got a septic patient here, not just a nice little UTI that's going to get antibiotics and go home. But then let's help our students identify the inflammatory response, systemic inflammatory response syndrome and SIRS and what it represents. Question 1. Now, medical orders come. State the rationale and expected outcomes for the medical plan of care. So now I've got 5 orders. Start an IV, bolus, Tylenol, ceftriaxone after cultures, morphine, IV push. And I could even make that morphine a 4 milligram or a 6 milligram, and then begin to say, what orders should the nurse question? That's going to be a Next Gen question, by the way. You can do your case studies. So easy to structure using Tanner's framework. And again, our students must understand the rationale for the medical plan of care as well as the nursing plan of care. What's the rationale for the IV, the fluids, the Tylenol, as well as the expected outcome of the medical plan of care? When they can think like a doctor or think like a provider, they're also thinking like a nurse at a very basic level. Then the third question, what's the nursing priority and plan of care? So again, nursing process is never going to go out of style. That's responding of Tanner. And that's also the next step of Next Gen, is that responding. And so what's the plan of what's the priority? The priority interventions, the rationale for the interventions, the expected outcomes. Those are all identified in the cases that I've written. And then, we need to also care like a nurse. Tanner's framework, what I love about Tanner that the NCSBN model will never be able to do is that Tanner's framework identifies some powerful principles of the importance of caring and engagement to the thinking of a nurse. That Tanner made the connection in her seminal article, Thinking Like a Nurse, a practice-based model of clinical judgment that she developed based on a synthesis of 200 articles in the nursing literature, that how a nurse cares, that engagement with the patient influences how the data is noticed. If a nurse doesn't really care, like Nurse Ratched from One Flew Over the Cuckoo's Nest, they're not going to notice or pay attention closely to clinical data. That's really important. So let's talk about psychosocial, holistic care priorities, caring, comfort, emotional support, spiritual care. And then finally, what are those educational priorities that need to be addressed to promote health and wellness for this patient and family? And that's another 2 pages. 5 questions. Part 2 is only 2 pages. And let's go ahead and just take, I think that's the last one in my thing here. Yes, it is. So let me just go ahead and go off share here. And I'd love your feedback. I'd love any thoughts that any of you have if you've used any of the skinny reasoning cases or any cases of your own. I just want you to see that, what, it isn't hard to bring clinical realities into your classroom. You just have to be willing to change and make that decision to. So, if I would give you some takeaways from what I've learned in my journey of using case-based learning and the value of that in my content, is that clinical reasoning is a skill that needs to be practiced, just like sterile technique. And that's why simulation and even clinical experiences, which can vary so widely, are not going to develop clinical judgment. That's one of the reasons our students are struggling. Even with the pandemic, they didn't get those reps. But realistic scenarios that integrate Tanner's framework and repetitively practice noticing skills, interpreting skills, responding skills, and evaluative reflecting skills. If we do that repeatedly, ideally every week, I want to raise the bar for every one of you listening tonight. Make it a priority to do active learning of some kind in every time you teach. Make it stick with cognitive application. And so again, case studies are that foundation. I also want to share a strategy. And Amy, could you put this link in the chat on reverse case studies? One thing I want to share that I found very powerful is called the reverse case study. That's the Arby's. That's basically doing a little differently from time to time. In a reverse case study, and I have these in my membership. If you're a member of Keith RN's Think Like a Nurse, I have a template under the classroom tools where you can basically take a Keith RN case study, a skinny reasoning, and it's empty, but it has all the questions, all the framework of the assessment, vital signs, lab values, and the clinical reasoning questions. But the students, you give them one sentence. You say, let's say you're doing this content on urosepsis. You give them that first sentence of a patient that you create. And the students then develop. You give them the name, the age, the ethnicity, and the past medical history. And the students in small groups, they create the scenario of whatever it is that you expect of them. You could use this in fundamentals for anything related to therapeutic communication, safety, falls. You just create the scenario and the topic, but you just create the first sentence. The students create the scenario in small groups. They create the vital signs, if it's relevant, assessment findings that are expected, unexpected, diagnostics, and the thinking. Creation goes straight to the top of Bloom's taxonomy. Doesn't get any better than that. So bring in that creating knowledge. That's a powerful way to truly transform and flip your classroom. So Destiny says, I love this. Case studies are awesome. And, Destiny, the cases that I've written, are a little bit unique because they have a unique framework. There's only one Keith. And I just simply took what I experienced in practice as a nurse at the bedside, loving patient care, loving ER most of the time. And basically, then how does it unfold for me? And I wanted my cases to replicate the unfolding sequential sequence, as well as using Tanner's framework and nursing process to do that. And in closing, I just want to let you know that I've written a faculty guide called A Faculty Guide to Develop Clinical Judgment. And it's about 40 pages. It's less than the price of a case study, and there's a link that Amy will put in the chat. But I have taken the knowledge that I learned in my dissertation, as well as my observations as a nurse educator and nurse in practice, and put it all together to give you a resource to confidently develop and teach clinical judgment using case studies and other best practice strategies like the reverse case study are explained in much greater detail in the faculty guide, as well as some other handouts and resources for you. And so if you would like to purchase that, I'll give you a 20% coupon code just using KeithRN20 as a coupon code, and Amy can put that in the chat. And I also have a membership site for nurse educators. So I've got over 110 topics across the curriculum of skinny reasoning case studies that you can use in what I just shared with you tonight. You can use that in your classroom. You can use that in post-conference if you want to bring active learning. If you want to give your students an assignment, a student-focused activity in clinical, you can do the skinny reasoning. Or if you want a clinical replacement activity, I have what they call unfolding reasoning, which is over twice as long and geared for advanced students with a change of status and higher level reasoning questions to prepare them for practice. So I just want you to know that those resources are out there. And the membership has just gotten a complete upgrade. I've got new resources on next generation NCLEX, some new content and handouts to help empower educators. I don't want you to be fearful of next gen. We can confidently implement and use best practices to transform how we teach. We don't need to transform our curriculum. We don't need to go to concept-based or any other form of a curricular revision. We need to transform the way nursing is taught. That's the missing link, and that's what we've lost sight of the last 10 years. Since Benner's work came out, we've been focusing on concept-based curriculum, not transforming the way we teach. Now, we can do both, but we haven't been doing a really good job of that as a whole. And now we have next gen breathing down our necks as a result. And I just want you to know that every one of you can be that needed change. And I'm excited and really thankful to have the opportunity to share these strategies with you. And I hope you found this helpful. I want you to know that this information is also in a YouTube. I have a YouTube channel called Think Like a Nurse, and you can subscribe to it. And I've got a YouTube on this very topic, and every topic I've been doing, I've got a 3-minute condensed version. If you just want that need to know, you don't have to watch 40 minutes of a Facebook Live. So anyways, it's been a pleasure. And I also just want to let you know too what's coming. I wrote a student textbook, Think Like a Nurse, back in 2015, my second edition, adopted by programs around the country, helping distill these clinical reasoning skills in a very practical and practice-based manner. The third edition is being revised right now, and it'll be out by the end of the year. It's a complete rewrite, and I just want you to know it's coming. And so if you are looking for a resource for your students to help them understand in a very simplified manner these clinical reasoning skills that I'm talking to you about tonight, and as well as other skills to help them be practice ready, that'll be coming by the end of the year. So I'll be sharing more about that, but I just want to give you a little teaser that this is coming. So anyways, next week we'll be talking about transforming the clinical and making learning active to develop clinical judgment, whether it be a virtual clinical or you're real in the practice setting, some very practical strategies to help empower you to strengthen clinical learning, developing and milking clinical for everything you've got. And so anyways, I just wanted to see if you've got some closing questions. We've got a few minutes here, and I just want to see what we have here. And just want to say thank you, Joe, for the membership and the resources. That was one of the things that's not out there for educators. There is no resource like the membership. And I realize as a new educator, I want good case studies. I want clinical paperwork. I want simple tools I can use that are just ready to rumble. There was nothing out there. So I just developed by time and the grace of God, literally hundreds of case studies, dozens of tools that are unique to the membership. So there's a link to the membership site. I'm not trying here to promote that, but I want you to know it's a resource, and departmental memberships I can offer at a significant discount. So if you want to get all faculty using cases and other meaningful active learning and things that will develop critical thinking with tools from day one in your program all the way through the end, the membership can meet that need. So I just want you to know you don't have to, you've got that as a resource for you. So anyways, Kathy says, thank you for the series. It's been helpful. Alicia says, wonderful information. You're welcome. Love your site. It's been great. And Destiny, I look forward to next week's live. And Destiny, we will be back in 2 weeks. I can't go every week doing this, but it's my pleasure to truly come every other week on these Thursday evenings. And just want to say thank you again for joining me tonight. I look forward to connecting with you in 2 weeks. And I want to thank you for all that you're doing to be part of the needed change. It really is my pleasure to partner with you. And I want to thank you for all that you're doing, because you're taking the hard but narrow path that leads to transformation. And you are not going on that broad path that so many other educators are on that are not being part of the change. You be a 11. May you be used to make a difference, to impact your departments and take the things that I'm sharing. I want to see kind of a leavening take place over time to see the transformation, the practice gap shrunk, and let's do all that we can to better prepare our students for practice. And thank you for all that you're doing to be a part of that change. Blessings to you all. Have a good night.